Good morning. Welcome to MHIF Grand Rounds. And thanks to Pfizer and Bristol Myers Squibb for their support of this. It is an honor for me to have the opportunity to introduce Dr. Chris Pedersen. He's from Minneapolis, growing up in South Minneapolis. He has long been part of the MHI family. Many of you know his father, Dr. Wes Pedersen, but probably very few of you remember that Dr. Chris Pedersen was one of the MHIF class. I was unable to find any photographic evidence of this, but he was part of the 2006 class. Following his graduation from Benilde, Dr. Pedersen attended Iowa State University, majoring in chemical engineering. He obtained his medical degree at Creighton University and then went to Dallas for general surgery residency at Baylor. Dr. Pedersen completed his vascular surgery fellowship at the Minneapolis Heart Institute in 2023, and we were very excited to have him join our practice following this. He has an interest in aortic aneurysms and carotid disease, and he'll be talking today about carotid artery stenosis.
Memory's good. All right, mic's still on? Yes, I think so. All right, so I'm going to go through carotid artery stenosis and ischemic stroke, some diagnosis and management, looking at best medical therapy, carotid endarterectomy, and stenting. Disclosures, I was a prior consultant for Philips Imaging Guided Therapy Corporation briefly. And then other disclosures, I'm a vascular surgeon, so I'm obviously got some implicit bias towards surgery, but I'll try to keep it fair. So like I mentioned, we're going to go over etiology and diagnosis of carotid artery disease and ischemic stroke and compare outcomes of carotid artery revascularization. So a little bit of history. Dr. Chiari reported in 1905 a 400 autopsy study where he found 7 patients had this mixed thrombus and carotid plaque, and 4 of them had suffered a stroke. Not until 1951 did Dr. Fisher really describe the atherosclerotic plaque of the carotid artery disease and its relation to ischemic stroke. And then in 1953, Dr. DeBakey, the famous surgeon in Texas, reportedly performed the first carotid endarterectomy, beating his longtime his rival, Dr. Cooley, although there's some debate whether who did it first, up until Dr. DeBakey produced this operative report dated in 1953. And interestingly enough, he didn't report this surgery until 1975 with 19-year follow-up data. And just to point out how many assistant surgeons Dr. DeBakey gets, he got 3 to help him with surgery. Not something we get nowadays. And then last couple decades, transfemoral stenting in the late 90s or 80s, sorry. And then in 2009, the era of TCAR has started. So just as like a kind of a background on stroke and carotid artery disease, there are approximately 800,000 strokes in the United States every year, 600,000 of those being first ever stroke. Women have a lifetime risk of 20%, and men have a 17% lifetime risk of stroke. It costs annually about $45 billion. It is a leading cause of long-term disability and direct cause of death in 1 in 20 people. And 80% of stroke is ischemic stroke. The remaining 13% is a combination of intracerebral hemorrhage and subarachnoid hemorrhage. So when we actually look at risk factors for ischemic stroke, obviously, as mentioned, age is a big one, sex is another one. Women tend to account for a higher percentage of stroke mortalities, but that's believed to be secondary to their longer lifespan. Patients with hypertension, with their blood pressure controlled less than 120/80 have half the lifetime risk of stroke. Patients with atrial fibrillation have 3 to 5x the risk of stroke. Cigarette smoking 2 to 4 times. Diabetes also clearly related, increases risk, especially in those less than 65 and women. So how does carotid artery stenosis actually cause ischemic stroke? Well, of ischemic stroke, 20% of those are related to carotid artery stenosis. So a good percentage of them are related to that. So the two mechanisms are embolization and hypoperfusion. Hypoperfusion is actually pretty rare and really only seems to show up with 4-vessel disease affecting both the vertebral and carotid arteries due to the rich collateralization in the brain. And embolization occurs, like I said, for the majority of these things. Dr. Hollenhurst actually reported this embolization being seen in the retinal arteries, and you can see one of these right here, this guy right there. It's actually caused, or now called a Hollenhurst plaque. So patients have carotid artery disease, they're at risk for ischemic stroke. So how can we find patients that have asymptomatic disease, which we'll talk about first before talking about symptomatic carotid disease? How can we screen them, diagnose them, and then improve their risk factors? So unfortunately, there's no randomized trials evaluating screening for carotid artery stenosis. We just have consensus statements and some guidelines. So obviously, like, we don't screen everybody, and the reason we don't is that the prevalence of severe disease is actually rather low, less than 3% in the general population, and risk of stroke in these people is less than 1% per year. There may be some factors to the plaque that may predict increased risk of stroke, but nothing seems to be strongly validated in the data. So does anyone actually listen for carotid bruits here? No? Okay. I would have thought there'd be more. Seems like a lot of the cardiologists listed for them. It's actually interesting that in the Framingham study, carotid bruit, well, patients who had strokes and a carotid bruit more often had a stroke in a different vascular territory than their carotid bruit, which just means that the carotid bruit is a kind of a marker for atherosclerosis and cerebral vascular disease. So other than listening for bruits, the way we can do this is carotid ultrasound. So as I mentioned, no trials have compared screening versus not screening, but this joint statement by American College of Cardiology, American Heart Association and Stroke Association, ACR, and SVS said that carotid duplex is not recommended for routine screening of asymptomatic patients who have no clinical manifestations of or risk factors of atherosclerosis. However, they did note that it was reasonable to screen for asymptomatic individuals who have a carotid bruit, which I feel like is how most patients get referred to vascular for asymptomatic disease. Someone has listened and found a bruit, they get a subsequent duplex, and then we end up seeing them afterwards. So some other kind of more recent guidelines and statements. Again, American Heart Association says that screening low-risk populations for asymptomatic disease is not recommended, and USPSTF said that, again, screening in the general population is not warranted. And they actually said moderate certainty that the harms of screening outweigh the benefit for these patients. And finally, the Society of Vascular Surgery said that you should consider asymptomatic patients for screening if they're at increased risk for carotid stenosis, and obviously importantly, if they're actually willing to undergo a carotid intervention. Because if we're going to screen these patients for carotid stenosis, they probably should have a benefit to actually getting surgery. So other than ultrasound, ways we sometimes find carotid stenosis, well, there's 4 imaging modalities. Like I mentioned, carotid duplex is the most common one and used for asymptomatic disease. The other 2 are CTA, MR angiography, and catheter-directed cerebral angiography. The cerebral angiogram is considered the gold standard in what we compare these other tests to, and was used for a majority of the initial carotid endarterectomy studies for diagnosing the severity of stenosis. So carotid duplex, advantages: it's non-invasive, it's safe, it's inexpensive. Disadvantages: it's operator dependent like all ultrasound is. Less precise in determining stenosis, less than 50%. It's also less sensitive for carotid occlusion. And we only actually get a kind of a range of stenosis based on the carotid artery velocity and ratio of the peak systolic velocity. So the next one is magnetic resonance angiography. Can be done with or without gadolinium, without using this time-of-flight imaging. It's obviously more expensive, takes longer. Actually, it takes about 60 to 90 minutes for the study to get done. Of course, there's limitations in terms of implants. Motion artifact can degrade the image quality. While it is pretty accurate for stenosis and occlusion, it's less accurate for detecting moderate stenosis and tends to overcall, so to speak, carotid artery stenosis and make it look worse than it actually is. CTA is probably the more common one we use, especially in symptomatic patients. Provides superior anatomic detail, provides good evaluation of arterial lumen, surrounding tissues. It's quick. Obviously, there's radiation and contrast exposure with these things, but it is 97% sensitive and 99% specific for high-grade stenosis. And most importantly, surgeons are very familiar with it, know how to use it and interpret it. And then finally, catheter-directed cerebral angiography, provides entire evaluation of the carotid artery from the base of the neck up into the brain. It can give you lesion morphology. It can also tell you about collateral circulation through the brain. Disadvantages, it's invasive. It has costs. It's associated with 1 to 2% rate of events, including neurologic and stroke events. So it's not a freebie by any means. So now that we've found these patients who are asymptomatic and have carotid stenosis, what do we do with them now? Well, first thing is going to be risk factor modification. As I mentioned, risks previously, smoking cessation, glycemic control, blood pressure control, improving diet and exercise, weight loss, major impact. Additionally, medical therapy is also plays a big role in this, not just for reduction of stroke risk, but for other cardiovascular mortality. When you actually look at the effect of antiplatelets, specifically aspirin, the actual data on its ability to reduce long-term stroke is kind of mixed, but certainly has reduces the risk of CV events and deaths. When we look at the statin medications, patients on a statin versus no statin have a 10-year risk of stroke of 13% versus 24%. And for blood pressure control, we know that it reduces progression of disease. And for every drop in their systolic blood pressure of 20 or diastolic of 10, we see a increase over the normal as a twofold increase in stroke or death. So got patients on medical therapy. They're now eating healthy and exercising 10 times a week. When do we repeat this ultrasound that we got? Because now we have this study that shows that, hey, they've got stenosis. How often should I recheck? Does it get worse? Well, this kind of appropriate use criteria document came out and said that for the first year after detecting stenosis, if they have severe stenosis, it seems appropriate to check within 6 months. But beyond that, the frequency after the first year seems to be that anyone with moderate to severe stenosis should be checked every 6 to 12 months with uncertainty for checking or following up on mild stenosis. And certainly not, patients with just plaque with minimal stenosis have no real benefit in repeating that ultrasound. All right, so then beyond medical therapy, follow-up ultrasounds, when should we actually revascularize these patients? So in the 80s, a few trials were designed, the big ones being this VA trial, the ACAS trial, and the ACST trial. Probably the bigger one we talk about most is the ACAS trial. And they looked at patients with 60 to 99% stenosis who are asymptomatic and randomized to best medical therapy versus best medical therapy and carotid endarterectomy. And at the time, best medical therapy was aspirin and, quote, modification of stroke risk factors. So no statin, minimal blood pressure control at the time. And what they found over 5 years, best medical therapy group had an 11% chance risk of ipsilateral stroke, perioperative stroke or death, compared to the best medical therapy plus carotid endarterectomy of 5%. All right, so pretty big difference there. And then a meta-analysis of all these studies showed that CEA was associated with an absolute risk reduction of 1% per year over 3 years, which computes a number needed to treat of 33 patients just to prevent 1 stroke. So of these patients with asymptomatic stenosis, that's kind of like all comers. If we actually stratify them by their age, really age seems to have an impact on their benefit. When they actually looked at patients who were over 75 years old, their absolute risk reduction for stroke was much less. And in fact, 90% of those patients in the ACST trial over 75 died for reasons other than stroke in that trial, making CEA seemingly have little benefit for these elderly patients. And that's part of why the SVS recommends patients should have at least a 3 to 5 year life expectancy and have a perioperative stroke or death risk of less than 3% to benefit from carotid endarterectomy. All right, so these are, like I said, mentioned, these were pretty older trials now. Some more recent data out of JAMA from 2022. They had 3,700 patients. They looked at a mean follow-up of 4 years, and these patients had, again, severe stenosis, diagnosed by ultrasound. Now, this wasn't a randomized trial, but they just did a retrospective, look at patients who were on what we would now consider best medical therapy, statins, antiplatelet, blood pressure control. And what we see now is that it looks like the risk of stroke is much lower on this newer best medical therapy, probably about 1%, which puts you right in line with the previous studies of carotid endarterectomy having a 5% risk of stroke over 5 years. So it sort of seems like carotid endarterectomy may not be that beneficial for asymptomatic disease. However, let me back up. So that's for like all 50 to 100% or 99% stenosis. So if we look at it and break it down by, or stratify it by the actual percent stenosis, turns out, I think that patients with more severe stenosis, greater than 80%, may have more of a benefit than just 70 to 99% stenosis. So in this meta-analysis and like Oxford Vascular Registry, they reviewed 5-year risk of ipsilateral ischemic stroke and stratified it by 2 different cut points, one being 70 to 99% stenosis versus 80 to 99% stenosis. And you can see the difference here between these two is pretty minimal, suggesting that that group of 70 to 80% stenosis may not get much benefit, and that the actual cut point for treating asymptomatic disease with carotid revascularization should probably be greater than 80%. All right, so asymptomatic disease, most importantly, risk factor modification and follow-up imaging, sometimes indicated, and carotid endarterectomy, for the guidelines, is recommended at greater than 70% for asymptomatic patients, but based on more recent data, newer best medical therapy should probably be reserved for patients greater than 80% who have a life expectancy of 3 to 5 years. So how about symptomatic disease? This is like the whole other side of things. I'm not going to get into the whole treatment of acute ischemic infarcts, but yeah, clearly patients with less than 6 hours of onset of symptoms should be evaluated for potential systemic thrombolysis or percutaneous thrombectomy. That's really more in the realm of neurointervention radiology than vascular surgery. So, other than modifying risk factors, who would benefit from carotid endarterectomy? Well, I'll get into the studies here in a few minutes, but in general, patients likely to benefit are moderate to severe stenosis, which is patients with more than 50% stenosis of the carotid artery. Unlikely to benefit are patients, and someone we don't actually do this on is anyone less than 50%, severe comorbidities that would limit their ability to tolerate surgery, and patients with severe persistent disabilities don't seem to have much benefit, and then there's no benefit to carotid revascularization with total occlusion. So big trials are NASCET trial and the ECST trial. In NASCET, they enrolled patients from 1998 to 91. They stratified it by percent of stenosis. They followed them over 5 years. The severe stenosis group, 70 to 99%, they actually stopped after 2 years due to the significant benefit with carotid endarterectomy, reducing the risk of stroke over 5 years from 26 to 9%. In the other groups, the mild stenosis found no benefit to carotid endarterectomy, and while still significant for 50 to 69%, the effect is less so than patients with severe stenosis. In the European carotid surgery trial, they had another 3,000 patients. They determined their level of stenosis a little differently than the NASCET trial. This kind of represents how they measured the carotid stenosis level. And they looked at, again, different cut points for stenosis and their risk of stroke at 3 years. And patients with 80 to 100% stenosis found 15 versus 26% stenosis. It's similar to the NASCET trial. And actually, when they went back and corrected the ECST stenosis numbers to what would be the NASCET equivalent, they found the same, that greater than 70% clear, obvious benefit, and then the group of 50 to 69% moderate benefit. And again, no benefit less than 50%. So carotid endarterectomy, clearly beneficial in these patients with symptomatic stenosis. So when do we actually go and revascularize them? It's always an important question. So what we want to do is balance the risk of hemorrhagic conversion from their stroke with the recurrence of stroke. So currently the recommendation is to wait at least 2 days and to perform the surgery before 14 days. We found that in this study in Italy of 500 patients, if surgery is performed less than 2 days, the risk of stroke actually increased by a pretty significant amount. And then before the 14-day cutoff, we're trying to like I said, reduce the risk of recurrent stroke and TIA. Clearly, large benefit the earlier you do that. And in fact, actually past 6 months, we don't even consider those carotid artery symptomatic anymore. And then 2 other kind of fringe reasons of ischemic stroke, stroke and evolution and crescendo TIAs. We don't see very often, but they have a much higher risk of stroke and death with carotid endarterectomy versus other ischemic stroke. But if you actually correct that to patients who had less than a 30% MCA territory infarct, the actual rates of stroke and death are more in line with crescendo TIAs, but still elevated in stroke and evolution. So as I've mentioned, carotid endarterectomy is kind of the baseline, the gold standard, been done for 70 years now. Just as a refresher for the non-surgeons, it involves exposure of the carotid bifurcation in the neck, clamping the arteries, opening it, removing this plaque seen here from the artery, and then patching it. Okay. So just to go through some risks of just this surgery itself, as I mentioned, kind of the stroke trials and just the risk of stroke with that was already kind of mentioned. Again, MI risk is about 2%. We'll see that more in some other trials. A feared complication, although pretty rare, is cerebral hyperperfusion syndrome. This is thought to be due to the dysregulation of the microvasculature in the brain. As it's been chronically hypoperfused, the microvasculature is dilated, and then once the return flow to the brain after the endarterectomy, it loses its ability to contract and restrict blood flow, and it can cause seizures, cerebral hemorrhage. It's pretty devastating sometimes. So that's often why we are pretty strict about our blood pressure control after a carotid endarterectomy. Hematoma, it's an uncommon complication, happens about 3% in the trials. It can be something as a small superficial hematoma to devastating airway loss, requiring emergent tracheostomy and evacuation in the operating room. The one is cranial nerve injury we talk about. Occurs in approximately 5% if you look at the trials. Hypoglossal nerve being the most common, causing some swallowing and tongue dysfunction. A vast majority of these will resolve regardless of the nerve that's injured. By 3 months, less than 1% of these patients who have a nerve injury or palsy have resolution of their symptoms, fortunately. Rarely do we ever see infection. The neck is pretty well vascularized. Most of the time, it's pretty rare in general, but most can be just treated with antibiotics. But infections can appear late. I think it happens less now by using a bovine pericardial patch to patch the artery versus, in the past, people were using Dacron patches. But it also can be a pretty devastating issue if, there's a sinus tract or they have a blowout of their patch. And then long-term, we talk about restenosis of the carotid artery. So it's reported to be about 5 to 10% at 5 years. 2 to 10%. It's kind of two camps. There's the early restenosis, which tends to be a more like highly cellular and minimally ulcerated hyperplasia as a low risk of symptoms. And then the late recurrence beyond 2 to 3 years tends to be like true recurrence of disease and maybe at higher risk for causing symptoms. Again, since most of these tend to be hyperplasia, we tend to not treat them until they either get severe or it's more of a late presentation. So carotid endarterectomy has this enemy, the transfemoral carotid artery stent. It certainly has its place. Scenarios where it may be useful include inaccessible carotid lesions. Sometimes the carotid bifurcation is much higher up under the mandible, and surgical exposure of that area can be challenging. Occasionally we talk about having an ENT surgeon dislocate or perform a mandibulectomy or otomy to help expose that, but that's pretty morbid, and I've never actually seen or heard of anyone doing that. Other areas that may be beneficial are radiation-induced stenosis, because it, again, tends to be a more hypercellular, non-ulcerated plaque that may have less risk of stroke from the procedure itself. Restenosis after carotid artery seems to be a benefit for stenting patients. And patients, obviously, who are too sick to undergo surgery. And then finally, patients with unfavorable neck anatomy is another big one. Patients who have had contralateral surgery with vocal cord paralysis may not be good to undergo surgery on that other side, with risking injuring both sides of the vocal cord, which could need a tracheostomy long term. Patients with open tracheostomies may be at higher risk, and then prior radical neck dissections for head and neck cancer, for example. So what happens when we actually look at these two? So the big trial is the CREST trial, the carotid revascularization endarterectomy versus stenting trial, published in the New England Journal of Medicine in 2010. It was a multi-center trial. It was unblinded, parallel group, randomized across a bunch of centers in the United States and Canada. They had 2,000 patients split evenly between stenting and carotid endarterectomy. They used a composite endpoint for their primary endpoint of stroke, MI, or death during the peri-procedural period. or ipsilateral stroke within 4 years of randomization. In their group, 40% of the patients randomized were asymptomatic. And as you can see, the composite endpoint of just the peri-procedural endpoints of stenting versus CEA, they have pretty similar result, 5.2 versus 4.5%. Death seems to be equivalent. And then the trade-off between the two is that carotid artery stenting seems to has more stroke, but CEA has more myocardial infarction. I will add the caveat that myocardial infarction in this group did include patients with an asymptomatic CKMB or troponin elevation, which is probably one of the main criticisms of the trial with this endpoint here. But if you look out to 4 years and 10 years with these composite endpoints, they seem to have equivalency. So it would seem that if you can get past the stroke risk with stenting, you may have a long-term equivalency for these things. Now, more recent trial, the ACST True Trial, published in Lancet in 2021. Again, looked at asymptomatic patients. There are 3,600 of them to CEA or carotid artery stenting from 2008 to 2020, followed up for 5 years. And if you look at this trend here, the procedural death or fatal or disabling stroke risk seems to be about equivalent for these things. But if you include any stroke, not just fatal or disabling strokes, there's a clear difference here over the 5 years. Again, it seems to be, with these lines, kind of parallel here past this initial peri-procedural risk that carotid stenting and endarterectomy are equivalent. So how do we get past the initial carotid or the stenting stroke risk? Well, fortunately, someone came up with this idea of TCAR, transcarotid artery revascularization. So it's a hybrid surgical approach with exposure of the common carotid artery just above the clavicle, with introduction of a sheath into the common carotid artery, and then using this reversal of flow device, we actually clamp the common carotid artery below the sheath and pull blood out of the sheath from the brain and dump it back into the femoral vein with this filter here to collect any debris. So advantages of this are you avoid the aortic arch, which seems to be a major source of stroke during carotid artery stenting. But it does have anatomic constraints. So the common carotid artery has to have at least 5 centimeters of length in order to actually introduce the sheath safely without disrupting or coming in contact with the carotid bifurcation plaque. And the common carotid artery needs to be at least 6 millimeters, which is majority of patients. So now that we have this newer procedure, which could potentially lower the risk of stroke because we're avoiding the arch, we're reversing flow, we don't have to put anything past the stenosis before deploying a stent. What does the data actually show? After the initial kind of first-in-man and pre-market approval studies for the TCAR procedure and device, they kind of did this propensity-matched scoring system between patients who underwent TCAR versus transfemoral stenting. It's not a true randomized trial. And they looked at outcomes here. So in hospital stroke or death, better with TCAR versus transfemoral stenting. Stroke, clearly less. Death, about the same, as well as MI. And again, there's some access site complications for both of these, but pretty equivalent here. More important study, I think, is the Roadster 2 trial. I forgot to remove that. That's a Tesla Roadster. So Roadster 2 trial was this single-arm post-market approval study of TCAR, and they looked at patients who were high risk for carotid endarterectomy, whether that be anatomic or physiologically high-risk patients undergoing CEA. They had 632 patients. Most of them were asymptomatic, as in most trials. The primary endpoint being procedural success which included both the technical success of the procedure plus stroke, MI, or death within the 30-day postoperative period. And with this trial, we see that the risk of stroke when they're following the protocol as written by the trial, their actual risk of stroke over 30 days is 0.6%. Very low risk of death, and MI, and a composite risk of 1.7%. So this seems to get us past the initial stroke risk of carotid artery stenting. So looking ahead, that should be later. No, it's not. So what's to come down in the future? ECS2 trial is finished completing recruitment of patients. They're waiting for 2-year follow-up data, looking at asymptomatic and symptomatic stenosis. The CREST-2 trial, I think, is nearly done recruiting. This is now a 3-arm trial versus CREST-1. Now they're looking at best medical therapy versus carotid versus stenting. And then the Roadster 3 trial was the follow-up of the TCAR trial, which is more generalized from just high-risk patients to all like standard risk patients, physiologic or anatomic, with our own Dr. Jim here as one of the national PIs for that study. So in summary, carotid stenosis is a significant cause of ischemic stroke. Screening is beneficial in the correct population, not just general all-comers. Cardiovascular risk factor modification is crucial for these patients. They tend to not just die from stroke, but probably more often die from coronary artery disease. There is a benefit to revascularization in asymptomatic patients. I think there's still more data to come on that, what the actual effect is. I think best medical therapy is going to be proved to reduce the number of patients who will benefit from asymptomatic revascularization. And the cutoff point may be higher at 80% rather than kind of our standard 70%. For symptomatic patients, revascularization is warranted and indicated and beneficial for patients with at least 50% stenosis. Carotid endarterectomy, long been a safe procedure in the properly selected patient. TCAR has equal stroke risk to CEA and less than that of transfemoral carotid artery stenting. Any questions?
Thanks, Chris. Any questions here or any online questions?
There's no questions in the Q&A pod. There is a comment from Barb Chacko, who's just reminding folks that there's a SVS PSO national database, and the website is vqi.org, and I can put this link into the chat pod for our vocal folks or virtual folks as well. But if you have any questions for our virtual folks, please put that in the Q&A pod.
Thanks, Chris, for that nice talk. What can you tell us about the experience here in terms of numbers and what type of procedures are you doing, and that we would find of value to hear?
Sure, yeah. We do carotid endarterectomy here, and frequently carotid artery revascularization or TCAR. I don't know the last time a transfemoral stent was placed here, probably 10 years maybe.
Neuro IR does some transfemoral stents. I think, yeah, if a very limited number. Typically, the neuro IR doctors here are a little reluctant to put stents in during the carotid revascularizations for strokes or like thrombectomies and things because they've had some bleeding complications from dual antiplatelet therapy. So frequently they treat with just an angioplasty to open the carotid, and then they refer the patient to us for CEA or TCAR, and subsequently.
Yeah. What percentage are you doing surgically versus TCAR?
I would probably say 60 to maybe 70% are carotid endart, maybe 30% are TCAR. I don't have exact data on that, but that's kind of my feeling on it.
I said recently 20%
20%,
TCAR,
okay.
but it's getting slightly higher with like you and Dr. Leckie doing more as well.
Is there a reason for that, given the data that you showed? Is it? Go ahead.
Yeah, no, big part of it is patient selection and anatomy. Patients with higher lesions before TCAR or before transfemoral stenting, we would just kind of have to struggle through it and make it work. Contralateral occlusion is a big one that we see, I think is better with TCAR. You can shunt these patients during the surgery to keep cerebral perfusion up, but shunting is more challenging. And TCAR is one of the indications for doing TCAR is carotid or contralateral occlusion. Physiologically, is I don't think as frequent as an indication for doing TCAR here, but certainly is a factor in terms of how sick patients are, whether or not they can undergo an open surgery. So honestly, a lot of it I think comes down to anatomy.
And we just were able to, before, a year and a half ago, we were only able to do high-risk criteria patients
Outside of a trial, yeah.
outside of the trial, but now we have Medicare.
Has approved it for standard risk patients.
Great. Great talk, Chris. Josh Buckler, one of the general cardiologists. I had two questions.
Yeah.
First is more just out of curiosity. So when you do the TCAR and you've got that little filter thing there and you turn, you're done with the case, you turn it upside down. Do you get a lot of junk out of it? I mean, is it really remarkable?
Variable. Sometimes it's a bunch of stuff, sometimes it's nothing.
Okay. I mean, you wonder what's going downstream. I think anytime we do any of these interventions, we always wonder, what are we sending flying downstream?
Yeah.
The more interesting question is, in terms of coming from a general cardiology standpoint, one thing that I think we don't do as well here as we could is there's so much overlap between risk factors and screening and treatment of all these cardiovascular patients. I think there's a lot of patients that we see that we're not probably screening appropriately enough for peripheral vascular disease. And likewise, there's a lot of patients who I'll see who, had a complication after a procedure and have not had an echo and followed. How do you see, in terms of our collaborative nature going forward with this, especially I know you'll be out with Laconia, so who do you guys want to see? How do we work together better going forward in terms of sort of, taking these patients who are clearly have, shared risk factor profiles and try to screen them appropriately?
Interesting. I don't think any outside of the symptomatic patients, so just asymptomatic ones. I think a referral to a vascular surgeon with at least moderate stenosis is warranted, at least for discussion of, risk factor modification and, just discussing the risk of stroke and how we can fix these things in the future. The ultrasound report will tell you 50 to 69% or greater than 70. When it comes to greater than 70%, we have to kind of figure out if they're really close to 80% or beyond that based on ultrasound or getting a subsequent CT scan. But long-term follow-up, I'm not sure how much benefit there is in seeing a vascular surgeon every year with a repeat ultrasound just to, follow these stenoses long-term, and maybe better in the hands of primary care or cardiologists for, their global risk factor modification.
Good morning. Regards patients that go to coronary bypass, we tend to order carotid ultrasound to all of them.
Yeah.
And it's very rare to have a combination or to find disease. They'll have some significant, some carotid disease, but it's not significant.
Yeah.
At what point is it worth to keep screening these patients that are hard atherosclerotic patients, but really don't have disease or they're asymptomatic? And finally, if then carotid ultrasound is enough, or you would rather have a CTA in this specific population?
Asymptomatic patients, well, first of all, I think asymptomatic patients just need an ultrasound. They don't need more advanced imaging unless the peak systolic velocity through that carotid artery is exceptionally high, like pushing 350, 400 centimeters a second. But in terms of CABG, like you mentioned, most of them are kind of a mild, moderate stuff, much less than the severe camp. When it comes to following these, I think it's probably the same. We don't really have any long-term data for monitoring these patients, like no randomized data for who needs to keep getting ultrasounds every year, every 6 months. The asymptomatic patient. carotid, you know, it's kind of this discussion sometimes about who should be revascularized prior to CABG. Certainly seems to be that whatever one you're symptomatic from should be done first. If you're symptomatic from a carotid and severe, coronary artery disease and need a CABG, should get the carotid done first. But if they're symptomatic from the coronaries, they should have that done. There's a question of whether you be concomitant surgery, doing the carotid at the same time, in the operating room doing the carotid and then doing the CABG. I don't think that happens very often. I know it doesn't happen here really ever. And I think data's pretty mixed on it.
Yeah, we've got a few, or there is one comment and one question in the Q&A pod. The comment comes from JJ, and the comment is, only recently did we get reimbursement for standard risk for TCAR. So we're still just increasing to about 30 to 40% TCAR. So I don't know if you have any comments to that, or if anyone in the room has any comments to that.
I think, one of the big controversies is that CMS, not only did they approve standard risk TCAR, they also, even though your data did not look very good for transfemoral stenting, approved transfemoral stenting as equivalent to transcarotid stenting, which, again, the data does not, at least, do you think that is warranted? How about that? I'll question you.
I'm obviously biased. I think in the patient who does not meet criteria for transcarotid artery stenting due to anatomy, we're considering for carotid revascularization is physiologically disabled. Let's say, shouldn't undergo surgery either. Transfemoral stenting may have a role there. There are some ways you can sheath the carotid arteries to the TCAR criteria. Putting on a conduit is a way that's been written about and described. But I think for standard risk, if they can undergo a TCAR or CA, that's the way to go.
Is the reimbursement amount the same for both procedures?
Yes, it should be. They're the same code. They're both carotid artery stenting, basically.
So economically, the transfemoral approach is probably less costly to the institution.
I would assume so.
I don't know if that's true or not.
I would think there'd be less equipment with the transfemoral stenting.
Yeah.
Great, thank you for that. The last question comes from Dr. Burke, who asked, what percentage of strokes are due to carotid disease?
Yeah, so in the ischemic category of stroke, that's about 87% of strokes. But so of that 87% that are ischemic, 20 to 30% are carotid etiology.
Thanks, Chris.